What is eczema? So I'm going to talk briefly a little bit about the pathogenesis of eczema, the clinical features, and a bit about the epidemiology as well. I think, like most diseases, eczema is caused by a combination of a genetic predisposition and then exposure to environmental factors, and it's that combination that sets people up to develop potentially disease. Historically, when there's been a lot of interest in eczema, particularly focused on the immune changes that are seen in people with eczema, and I think this has led a lot of research to be focused on things like the hygiene hypothesis and modulating diet to change eczema. But I think what's been happening more recently has been a change in focus in our thinking about eczema, so that we're also looking at the role of the skin in developing eczema. I'm a dermatologist, so I'm very focused on skin, and so I think it's very helpful to think about eczema primarily as a skin condition, and I think in terms of explaining it to parents, that's also quite helpful because it helps them place their focus on the skin care, which in eczema management is where the money's at. And so we've started looking more at this sort of leaky skin barrier and then the roles that triggers have in causing the inflammation, the immune dysfunction that we see in eczema, and that whole itch, scratch, inflammation cycle. The barrier of the skin is the very outermost layer. It's the stratum corneum. So for those of you who are struggling to remember your anatomy, this is a little cross-section of the skin with the dermis and the epidermis here. This is the epidermis, and the stratum corneum is this very top piece there. And the stratum corneum is made up of layers of cells which are called corneocytes, and they're sort of stacked up like bricks in a wall. And then around them there's this lovely lipid substance that's sort of waterproofing, and it's got a lot of other factors, and it's got antimicrobial factors, cathelicidins, defensins, all these things that help protect us from the outside world. And it's also got all these junctions between the cells, and these are all important in creating that barrier. And in fact, the model of the skin as a brick wall is one that's used quite a bit. I use it certainly quite a bit, and it's used quite a bit internationally. This slide comes from Mike Cork, who's a dermatologist in the UK, who's very interested in skin barrier dysfunction and eczema. And I find this is a very useful way when talking with families about skin function. So this is a normal skin barrier. So your corneocytes are your bricks, the lipid substance is the mortar, and the cornea desmosomes and the connections are like the metal rods that hold all that together to make you have a nice strong outermost layer. The reason that people have become a lot more interested in skin barrier dysfunction is that there's been a discovery recently of a particular protein called filaggrin, which has a very important role in skin barrier dysfunction that's been shown to be highly associated with developing eczema. So filaggrin's only one of very many proteins actually that are involved in skin barrier function, and I suspect we'll see more findings about some of the other proteins as well. But filaggrin's got a role in aligning the keratin filaments and making the bricks the right shape. It forms something called natural moisturising factor, which keeps the corneocytes nice and plump and helps with the lipid layer development, and it also maintains the pH of the skin, and that pH is important for maintaining the normal activity, a lot of the enzymes that are needed for that skin barrier to work. So for normal desquamation, for example, and for normal antimicrobial effects. And so low levels of filaggrin are much more common in people with severe eczema. So if you've got a genotype for very low levels of filaggrin, you're 3 to 4 times more likely to have severe eczema. And what's interesting is that low filaggrin is also associated with the development of peanut allergy, and that seems to be independent of whether you have eczema or not. And this led to some thoughts about whether actually it's that barrier dysfunction that may be important in that developing allergies. And so this is another hypothesis This was developed by Gideon Lack, who's an immunologist in the UK. And so his theory was that if you normally meet skin by eating it over this side, normal oral exposure, you get normal presentation of food proteins to the immune system, and you develop a normal tolerant immune response. And he theorised that if you have a faulty skin barrier, or if you have active eczema, you'll maybe presenting those food allergens through a broken skin rather than through the gut, and that leads to a different part of the immune system, and you develop this allergic type response to food proteins. And so this has sort of cascaded quite a lot of research looking at early introduction, can we prevent allergies by managing skin better, those sorts of things. So what is eczema? Well, eczema doesn't have a diagnostic test, it's a constellation of clinical symptoms. And so these characteristics are derived from a definition that was put out by the American Academy of Dermatology. And so it's a chronic or relapsing inflammatory skin disease, and its key diagnostic feature is itch. Eczema is itchy. If it's not itchy, then you have to be thinking twice about whether it's really eczema or not. Okay. You get a very typical eczematous rash, and I'll show you some photos in a minute, and you get a characteristic distribution, and that distribution changes with age. So in infants you'll get a lot more face, neck, scalp involvement and extensors of the limbs. Older children and adults, you get flexural involvement. Hand dermatitis tends to become more of a problem in adolescents and adults, but I see quite a lot of kids with it as well, to be honest. And it characteristically spares the folds, so the axilla and the groin typically are spared. And so if you've got involvement in those areas, then you might think a little bit more carefully about, have you got the right diagnosis? So this is a typical infant with eczema. Red, scaly, slightly papular, a little bit weepy, it's been scratched at, scoriated. And if you look closely, eczema histologically is described as being papulo-squamous, so you get small papules and vesicles, and you'll get flaking off of the skin. In infants, you often get this very widespread erythema, and I think what's really important to recognise, and there are some papers that support this, that this redness is often under-recognised in children with more deeply pigmented skin. In a white child, it's very easy to see, and somebody with very dark brown skin, this may not be visible, but you can often feel roughness. And so feeling and when you assess the skin is very important. And I wonder whether that's part of the reason that often Pacifica Maori kids are undertreated. I think the same applies actually to Indian and some other ethnic groups as well. So this is a typical infant with eczema. You see that extensive involvement around the elbows, scratching the thighs, and babies can scratch from very young. If you ask a mother of a first child who's 3 months old, their first child's 3 months old, you say, are they itchy or not? And they don't know, then the child probably isn't itchy, because if they're itchy, you can tell, and they'll get the wiggle to scratch their back, or every time you take something off, they'll be grabbing it. So it's usually reasonably easy to recognise. You see in the more darkly pigmented skin, the redness doesn't show as much, but you can see thickening and post-inflammatory pigmentary changes. This is typical flexural involvement. You can get weeping skin when it's more intensely inflamed. Again, lichenification, typically around the knees and the dorsum of the feet and the ankles, is quite common in children. We also see a type of eczema called discoid or nummular eczema. Nummular means coin-shaped. And it's a little different. It's perhaps not so associated with atopy as the more typical eczema. And you get these very well demarcated areas of very intense inflammation, but with normal skin on the surrounding areas. And of course, eczema predisposes to infection. So that's both with herpes virus, cold sore virus, and with bacteria, most commonly Staphylococcus. And if you're really lucky, you can get both at the same time. So this just shows some of the progression of eczema from childhood to adulthood. So an infant, facial, extensive involvement, childhood, flexural, and adults, a lot more occupational, hand dermatitis, that sort of thing. About 50% of people who've had eczema as a child get it recurring in adult life. So it's an underlying, I always tell people that you have a basic predisposition to eczema. It's just whether you've got actual manifestations at the time. Good question. So you see a lot of mums who've got babies, suddenly they get a hand dermatitis because they're washing all the time. So eczema, as Jan said, like many of the other atopic disease, the prevalence has just skyrocketed in the last 40 to 50 years. This is data from New Zealand showing, so from the Christchurch Child Development Study, the Auckland Birth Rate Collaborative Study and the Isaac Study, all have found prevalences of eczema in New Zealand children of around 15 to 20%. However, most of those kids probably don't have severe eczema. We don't have good community data from New Zealand. This data here in the pie graph comes from a study in Nottingham where they actually went out and examined people in the community. And they found that of people with eczema, about 84% of people have mild eczema. 14% have moderate and only 2% have severe. That may be a bit different in the New Zealand setting, but I do think it probably is right that most people do have mild disease. This graph comes from the Isaac study, and it just basically shows the prevalence of eczema in children aged 13 to 14 years. The purple graph shows eczema ever, and that's probably around 23 to 30% of people report that. However, I think what's particularly interesting to me about this graph is the grey bars, which represent severe eczema. Severe eczema they defined as waking up 2 nights a week or more because of your skin. And that is particularly problematic in Māori and Pacifica children. About, so at 13 to 14 years, it's about 3% of Pacifica kids, but at 6 to 7 years, it was about 6% of Pacifica kids are waking up to. All kids, not just those with eczema, are waking up 2 or more times a week because of their skin. And that's a lot. And that has a big impact both on the child and their family. And so the good thing about eczema, I suppose, it's not usually life-threatening, but I think it has a huge impact on families and on individuals. Itch is the most problematic thing. I don't know if you've ever been itchy, but it's really unpleasant. And the sleep disturbance, I think, is also really important. And so often one of my main treatment goals is to get kids sleeping at night. A sleepy kid that's asleep is a happy child with happy parents. This impacts on their behaviour and their learning. They also find that the amount of time taken to treat eczema is actually quite a lot more than most conditions, doing the creams over and over. They also dislike effects on their activity, and if their diet's restricted as well. Maybe miss school, can be impacted by bullying, can have effects on their self-esteem and confidence, and it can affect their opportunity for employment. If you've got a visible skin disease, it's hard to get work as a shop assistant or handling food. And it's been shown that children with eczema have twice the rate of psychological problems as their unaffected peers. This graph comes from a study looking at children attending an outpatients department in Dundee, and they gave all of the children with a variety of diagnoses the Child Life Quality Index scoring system. And this looks at things like effects of pain, effects on daily activities, clothing, all those sorts of things. And they looked at all these different conditions. Quite a few of them are skin-related ones, but not all of them. And so generalised eczema here, the higher the score, basically, the worse or the more the impact on your everyday quality of life is. So not surprisingly, cerebral palsy has the biggest impact. I don't think anyone's surprised by that, but generalised eczema is second, up there with renal disease and cystic fibrosis. Okay. Epilepsy down here, diabetes down here. Localised eczema is similar to diabetes in terms of day-to-day quality of life impact. And so this is not to be ignored, I don't think. I think also the impact on of eczema is not just on the children but also on the whole family and the whole household. Parents often feel guilty that their child's got eczema. They feel they've caused it in some way, and they're frustrated that they haven't got it better, because every time they go to the supermarket somebody tells them that they just need to do this and their child's eczema will go away, and that's really difficult. That can have effects on obviously parents' moods. It can affect issues with discipline and behaviour management. Children will scratch to get attention, they'll scratch for a variety of things, and it can have effects on that. Comments, big problem. Problem for a lot of dermatology patients, comments from strangers in the supermarket. The time spent on treatment is a big impact on the other parents, because it affects their ability to spend time doing more rewarding activities with the family. Can affect their ability to get childcare and to go back to work after taking time off to have a child. And I think this one's really important for us as healthcare professionals. It affects people's confidence in the healthcare profession, because every time they see somebody, somebody tells them something different. This table comes from a study looking at the impact of eczema compared to asthma on parental sleep. I don't know if any of you have children with eczema or asthma, it's probably quite relevant to you. So they asked the parents how many times their sleep had been disturbed over the previous week by their child at waking up. And so the children with eczema, the parents had been woken on average about 4 times in the last week, compared to asthma maybe 1 or 2 times. The parents had to get up a lot more for the children with eczema, 6 times in total between the parents. And when they were up for a long time. It wasn't just getting up, giving an inhaler and going back to bed. It was getting up, often having a bath, putting some more creams on, lying next to them, holding their hands so that they don't scratch, all those sorts of things. And so it is very impactful. And so, although eczema is a common inflammatory skin disease, it is a big problem. It involves both skin barrier dysfunction and immune changes. It is associated with other atopic disease, and I think it has a real potential for significant impact on well-being, but I also think there's potential for very effective treatment in the majority of cases.